Hello and welcome to our new topic. Today's topic is about diuretics, a group of commonly prescribed drugs that are used to increase urinary output. They do it through various mechanisms. These drugs are useful in a variety of situations, including emergencies. Let's start. The learning objectives are shown. Please take a look. This slide introduces the concept of solute transport across membranes in renal tubules, which is necessary to understand how diuretics reach their site of action. 7 basic mechanisms are shown in this slide. 1. Convective flow, in which dissolved solutes are dragged by bulk water flow. 2. Simple diffusion of lipophilic solute across membrane. 3. Diffusion of solute through a pore. 4. Transport of solute by carrier protein down electrochemical gradient. 5. Transport of solute by carrier protein against electrochemical gradient with ATP hydrolysis providing driving force. 6 and 7. Co-transport and countertransport, respectively, of solutes, with one solute traveling uphill against an electrochemical gradient and the other solute traveling down an electrochemical gradient. First 4 are passive transports where no energy is required, while the last 3 depend directly or indirectly on energy provided by ATP hydrolysis. This slide expands on renal tubular secretion. These transport principles are fundamental to understanding pharmacokinetics of diuretics. Most diuretics are secreted into the tubular fluid rather than filtered. Organic acid transporters and organic base transporters located in the proximal tubule play a major role in tubular secretion of weak acids and weak bases, including diuretics like furosemide, thiazides, and acetazolamide. Organic anions and cations are transported from blood to tubular cells at the basolateral membrane using specific carriers. These substances are then secreted into the lumen across the apical membrane. Many diuretics are organic acids that use these transporters to reach the tubular lumen, where they act from the luminal side. These transporters use secondary active transport mechanisms dependent on sodium gradients maintained by ATP-driven pumps. This means that diuretics require active secretion to work, and their action is reduced when secretion is impaired, such as in renal failure. Additionally, drugs like NSAIDs can interfere with transporter function and reduce diuretic delivery. This mechanism also explains why drugs like penicillin were historically administered with probenecid to prolong their half-life by reducing secretion. A diuretic is a drug that increases urine production by enhancing excretion of sodium and water from the kidneys. They interfere with sodium transport in different nephron segments. The primary goal of diuretic therapy is not simply to increase urine volume but to correct abnormal fluid retention states such as edema or hypertension. The term natriuretic is more precise than diuretic because most of these drugs increase sodium excretion first, followed by obligatory water loss. The physiological basis of diuretic action lies in inhibiting specific transport proteins in renal tubules, altering intravascular volume and reducing preload and afterload in cardiac conditions. Their effects on electrolyte balance vary and may cause imbalances such as hypokalemia or metabolic alkalosis. Safe and effective use requires knowledge of underlying renal physiology. Diuretics can be classified based on their mechanism and site of action. Carbonic anhydrase inhibitors act in the proximal tubule. Osmotic diuretics act throughout the nephron by increasing tubular fluid osmolarity. Loop diuretics inhibit sodium, potassium, and chloride reabsorption in the thick ascending limb. Thiazide diuretics inhibit the sodium chloride symporter in the distal tubule. Potassium-sparing diuretics act on the collecting duct either by antagonizing aldosterone or blocking sodium channels. ADH antagonists reduce water reabsorption in the collecting ducts. This classification correlates with their clinical use. For example, loop diuretics are suited for emergencies, while thiazides are preferred for long-term blood pressure control. Potassium-sparing diuretics help prevent hypokalemia caused by other diuretics. Classification by site of action also predicts their combination potential and adverse effect patterns. This slide provides a visual summary of the nephron with corresponding diuretic sites of action. Each class of diuretics acts on a specific transporter in a specific nephron segment. Carbonic anhydrase inhibitors act in the proximal tubule, loop diuretics in the thick ascending limb, thiazides in the distal convoluted tubule, potassium-sparing diuretics in the collecting ducts, and osmotic diuretics act throughout the nephron. The magnitude of diuresis depends on how much sodium is normally reabsorbed at that site. Since the thick ascending limb reabsorbs a large fraction of filtered sodium, loop diuretics cause the most potent diuresis. Let's discuss various diuretics in the next slides. Carbonic anhydrase inhibitors represent an early class of diuretics that act in the proximal tubule, where they reduce hydrogen ion formation by inhibiting carbonic anhydrase in proximal tubular cells. This reduces sodium-hydrogen exchange, decreasing sodium and bicarbonate reabsorption. As a result, more bicarbonate is excreted in urine, producing a diuresis with alkaline urine. However, because downstream nephron segments can reabsorb sodium, their diuretic effect is modest. They are weak diuretics but have specific clinical uses. Acetazolamide is the prototype drug. It reduces bicarbonate reabsorption and causes alkaline urine with metabolic acidosis. This class is not used for routine edema management but is useful in glaucoma, acute mountain sickness, and metabolic alkalosis. They are mainly used in glaucoma to reduce aqueous humor production and lower intraocular pressure. In acute mountain sickness, they help prevent respiratory alkalosis. Adverse effects include metabolic acidosis, hypokalemia, drowsiness, and paresthesia. Cross-allergy with sulfonamides may occur. Long-term use leads to tolerance because of compensation by distal nephron segments. These agents can cause renal stones due to altered urinary pH and are contraindicated in hepatic failure. This slide explains how acetazolamide helps in acute mountain sickness. At high altitudes, low atmospheric oxygen leads to hypoxemia. The body initially responds by increasing ventilation, but this leads to respiratory alkalosis, which limits further respiratory drive. Acetazolamide induces a metabolic acidosis by increasing bicarbonate excretion, which stimulates ventilation and improves oxygenation. The drug also reduces cerebrospinal fluid production, reducing cerebral edema due to hypoxia. This dual action makes it effective in preventing or treating acute mountain sickness. The drug works best when started before ascent. Osmotic diuretics like mannitol, a carbohydrate derivative, increase plasma and tubular fluid osmolarity. They are freely filtered at the glomerulus but not reabsorbed, which causes water to remain in the renal tubules and promotes diuresis. Their action is not dependent on any receptor or enzyme inhibition. They are pharmacologically inert but physiologically active because they shift water across compartments. Clinically, mannitol is used to reduce intracranial pressure in cerebral edema and to reduce intraocular pressure in acute glaucoma. It is also used to prevent acute renal failure by maintaining urine flow in conditions like hemolysis or rhabdomyolysis. However, it must be used with caution because it initially expands extracellular fluid volume and can precipitate pulmonary edema in heart failure. It may also cause hyponatremia or hypernatremia depending on water balance. Osmotic diuretics are contraindicated in heart failure and severe renal impairment. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!